Third session of the select is Gynecological Oncology. So, the first question is, which of the following is the mainstay of treatment for primary vulvar melanoma? See, vulval melanoma is a condition where the surgery is the only mode of best treatment, for which previously the wide local excision, instead of wide local excision, radical vulvectomy used to be done, which was a very cumbersome and would cause more morbidity to the patients. Now we have revised. I mean, that treatment has been revised. The main first line mode of treatment for this is to go for sentinel lymph node biopsy and wide local excision. See, sentinel lymph node biopsy is the recent trend even in other cancers also. Instead of going for MRI and other investigations prior ahead, even if it is done prior ahead, lymph node dissection is mainly depending upon the sentinel lymph node biopsy. If any of the lymph nodes are taken up, then only they are being dissected. So this definitely gives better morbidity, gives less morbidity to the patient and cause better outcome, and wide local excision will definitely add up to the good prognosis. So the best treatment here is wide local excision with sentinel lymph node biopsy, which is corresponding to option A. So the option B is radical vulvectomy with bilateral. That is obsolete now. The chemotherapy is not the first line of mode of treatment, and radiotherapy alone doesn't cure the disease. So as I said, that should be based on a wide local excision with sentinel lymph node biopsy, and other therapies like chemoradiation or should be add-on therapies, not the primary modes of option. Second question, a 62-year-old woman undergoes surgery for endometrial carcinoma. Histology shows high-grade endometrial carcinoma with 60% myometrial invasion, no cervical involvement, no lymphovascular space invasion. Molecular testing reveals an abnormal P53 pattern according to 2023 FIGO staging. What is her stage? See here, if you see, he has clearly given terms, and the stages according to the FIGO 2023 are based on the terminology. The correct option here is B, that is stage 2C corresponding to C, that is endometrial in high grade carcinoma with greater than 60% invasion. This ABN indicates abnormal. So if you see that ABN is abnormal, P53 is gene. So if you keep this mnemonic, you can easily identify. So the tumor classifications here, it is clearly given in the FIGO 2023, and the stage 1, if you coming to the option that is A, that is 1B, that applies to the any stage which is less than 50%. So here it is 60, it is greater than 60%, so it is not stage B. So stage the coming to the answer C is 1C. 1C refers to the aggressive histological histological types confined to endometrium without myometrium. Okay, and stage D, the option D is stage 2 AM pollen mutation. So this indicates that this tells that these are stromal invasions. So this doesn't applicable here. When the simple terminology here is P53 mutations, that is already given here, and stage 2C because it is greater than 60%, and ABN indicates abnormality. Third question, 59-year-old woman presents with postmenopausal bleeding. She is obese with BMI 34, who is nulliparous. The history of PCOS, and was on estrogen therapy for menopausal symptoms for 4 years. Which of the following best explains her increased risk of developing endometrial carcinoma? Endometrial carcinoma is an estrogen dependent tumor. Any woman who has got a prolonged estrogen exposure is prone for endometrial carcinoma. This should be the background along with the systemic metabolic factors. So if coming to all other options, the correct option would be here is chronic anovulation leading to prolonged unopposed estrogen exposure. So what I said is exactly corresponding. So nulliparous women, PCOS women who do not menstruate regularly will be exposed to prolonged estrogen conditions, leads to endometrial hyperplasia, which may turn into endometrial atypia malignancy. So As I said, all the major risk factors like unopposed estrogen, metabolic factors like obesity and PCOS, and estrogen secreting tumors, nulliparity, and tamoxifen use. Other options are option A, progesterone induced tumor. That is wrong. This is estrogen induced. Option C, increased androgen production. No, that is increased estrogen production is the cause. Option D, reduced level of aromatase activity in adipose tissue. No, this is wrong. This aromatase stimulus may cause PCOS, but estrogen excess conditions will only cause endometrial cancers. Question number 4. 56-year-old women with recurrent metastatic endometrial carcinoma presents after progression on prior platinum-based chemotherapy. Molecular testing shows mismatch repair deficiency of DMMR, microsatellite instability with SMSAH status. Which of the following is most appropriate system therapy option for her? C. Correct options are bevacizumab and B is pembrolizumab and C is megestrol estate and D is paclitaxel. So the correct option here is pembrolizumab, because this is the this is very useful for the conditions like recurrent and high advanced endometrial cancers with specific mutations of DMMR or MSIH. So it is approval is based on the durable response in the subset of patients where traditional chemotherapy has limits. So because this has got a very advanced receptor sensitivity, so for cancer conditions like advanced conditions, it is usually used. And the mechanism of action is it blocks the PD-1 receptors, and so it stimulates the T cell mediated autoimmune responses. So the conditions wherein we are anticipating aggressive and advanced cancers, we can go for these conditions. The toxicities are usually colitis and hepatitis and pneumonitis. The other drugs are like bevacizumab is usually for chemotherapy failure conditions, which is used. This is a kind of immunomodulator. Megestrol acetate is considered as a progesterone therapy, not a kind of immunomodulator system. And paclitaxel is a part of chemotherapy, which is used for recurrent settings, not for a prolonged use. Question number 5. A 62-year-old postmenopausal woman presents with bleeding PV. She is obese, hypertensive, diabetic. Endometrial biopsy shows well-defined endometrial adenocarcinoma with background of endometrial hyperplasia. Which of the following features are current, which differentiates from type 1 and type 2 endometrial carcinoma? See, type 1 and type 2 endometrial cancers are two different. Type 1 is a condition wherein it is estrogen dependent. So, prolonged estrogen therapy, which ultimately leads to endometrial hyperplasia with background risk of PCOD and hypertension, diabetes, and which are low grade, usually respond better to treatment, and with molecular mutations like P10, KRAS, and MSI genes. So, and prognosis is obviously good. And rest all are type 2 diseases. So, when coming to the options, the correct option here is A, that is type 1 tumors are estrogen dependent. So, when we coming to the option B, type 1 tumors are high grade. So, that is wrong. This is low grade. Option C, it is type 1 tumors are is estrogen dependent, and type 1 are low grade, type 2 are high grade. D, type 2 tumors usually occur in young women with PCOS pattern. No, type 1 are associated with PCOS and young women. Question number 6. In low resource setting, WHO recommends alternative strategies of cervical cancer screening management. Which of the following correctly differentiates see and treat? Approach from the screen, triage and treat. See, here are two conditions. See and treat is a condition wherein we have to catch the patient whenever we get. Screen, triage and treat the condition wherein we go in a protocol manner. So, if with this background, the correct option here would be B. C. Treat involves a single visit of visually inspected areas followed directly by the treatment, while screen triage and treat involves visually inspected areas followed by HPV testing, followed by triage means HPV testing, cystoscopy, further testing, biopsy needed, and then treatment. As I said, see and treat, screen, triage and treat are two different conditions. See and treat is to catch hold of the patient wherein chances of missing are very less. Screen, triage and treatment, as I said, we have to go in a step protocol manner. Question number 7. 15-year-old immunocompetent girl presents for HPV vaccination. According to WHO says recommendation, girls aged 15 to 20 years, which of the following schedule is most appropriate? SAYS is a strategic advisory group of experts. These are the one who have given guidelines for HPV vaccination. For this is the correct option is single dose, because for any women less than 20 a single dose would be sufficient. For women greater than 20 then booster dose and step on doses are recommended. So for this option, according to the SAYS criteria, as the girl is 60 between 15 to 20 years with immunocompetent. As the girl is immunocompetent, single dose is sufficient. So what are the SAYS guidelines here is, SAYS permits a single dose HPV schedule for women 9 to 20, enhancing feasibility. Two dose schedule remains acceptable. Option where programmatic conditions dictate. Full 3 dose regimens are reserved primarily for immunocompromised population only. That means if any person who is immunocompetent and less than 20, a single dose would be sufficient. Question number 8. Which of the following IHC markers profile is most characteristic of endometrial adenocarcinoma as opposed to cervical adenocarcinoma? Endometrial adenocarcinoma typically an estrogen dependent condition, which I already said. So it expresses estrogen and progesterone receptors. So the ER/PR status is definitely addressed at the time of IHC testing, so as to assess the prognosis. And with small patches of P16 are seen here. And this kind of ER/PR positivity is less seen in cervical cancers. And diffuse block P16 positivity is a surrogate marker for high risk HPV infections, and it is more indicative of cervical adenocarcinoma. So any conditions below the cervical cancer are more related to the HPV. Any conditions are above to the on and above the cervix are more related to the estrogen dependency. So the correct options here is B, so which indicates that ER/PR positive, Vimentin positive with patchy P16 staining. And when we coming to the option A is P16 positivity, strong positivity won't be there. And coming to option C, carcinoma in CEA anti positivity with ER/PR is more typical of cervical origin rather than endometrial origin. Option D, P63 and CK5/6 positivity indicates squamous cell differentiation, not glandular endometrial carcinoma. Question number 9. A 46-year-old woman with FIGO 2B squamous cell carcinoma of cervix planned for definitive chemoradiation. During intracavitary brachytherapy, radiation oncologist refers to point A and point B dosing. Which of the following describes the anatomical differences? The simple anatomical landmark for point A, point B in chemoradiation is 2 centimeter. If this is the cervical endpoint, cervix, 2 centimeter above and lateral to lateral from the cervical end is point A. 5 centimeter in the same line is point B. This is a simple basic principle wherein we target the brachytherapy points. So rest are all not corresponding to that brachytherapy points. Question number 10. In selection of patients for secondary cytoreductive surgery for platinum-sensitive recurrent ovarian cancers, AGO score includes which combination factors? The AGO score is, it is very difficult to pronounce. This AGO developed into a desktop trial series is designed to identify the patients with recurrent platinum-sensitive ovarian cancers who have likelihood of achieving complete resection after the cytoreductive surgery. So the important 3 clinical factors in AGO score are good performance status, specifically ECOG is 0, and absence of clinically significant ascites, and it should be less than 500 ml, and complete resection at the primary surgery. So that means no residual is left at the time of surgery. So patients meeting this triad have high probability of complete resection and at cytoreduction as demanded to the desktop studies. So further studies, and the desktop 3 further showed improved progression free and overall survival rate in AZO positive patterns undergone secondary cyst plus surgery plus chemotherapy versus chemotherapy alone. So other options like the other option, the B, higher ECOG presence of significant ascites advanced FIGO stage do not meet AZO criteria. When we coming to this option C, age greater than 70 doesn't come under AZO's Crozen system. And the coming to option D, prior response to PrAP inhibitors are unrelated to these are also not included in the AZO system. Question number 11. Which of the following best describes the mechanism of action of antibody-drug conjugates, that is ADCs, like mirvetuximab targeting folate receptors alpha in ovarian cancers? This ADC therapy, such as mirvetuximab, significantly targets the alpha receptors. These are folate reducing alpha receptors, which are expressed on the ovarian epithelial cancers. What this kind of receptor does is, which is binding upon to these receptors, they activate the ADC receptor complex and in India and initiates the apoptosis, that is endocytosis. Whatever cells are targeted here, they undergo autolysis. So this leads to the death of the cancer induced cells. So this for this, the correct option here is the B, binding folate reductase alpha on the cancer cell surface, leading to endocytosis and intracellular release of the cytotoxic drugs. This is the specific targeted chemotherapy, a kind of cancer therapy. The other options like direct inhibition of DNA synthesis is a traditional antifolate therapy, not a direct ADC therapy. Blocking angiogenesis via vascular endothelial growth factor inhibition is a mechanism of anti-angiogenesis drug method, not folate reductor alpha targeting ADs. Inducing apoptosis by upregulating tumor suppresses genes is a genetical anti-cancer mechanism, but not specific to ADC therapy. Which of the following statements suppose CA125 Kelm score is correct? See, this Kelm score is based on the CA125 elimination rate. So before treatment starting, we assess the CA125 levels, and once the chemotherapy is started, we assess the rapid decline in the CA125 levels. This rapidity tells us the prognosis of this malignant status, and we can assess how good is the response to this chemotherapy. This Kelm score, it includes this rapid decline of the CA125 in the first initial 100 days of chemotherapy, especially for ovarian cancers. It requires minimum 3 CA125 measures and quantifies the tumor decays, indicating that the chemotherapy response. The important feature is the score is not affected with the addition of any other third drug. Like in chemotherapy or anti-angiogenic agents, or to the carboplatin or paclitaxel by changes in administration schedule. So confirming it robustness for predicting primary chemotherapy response only. That means it is not in relations with the secondary or other drugs which are being added in the therapy. So it targets the primary chemotherapy response with CA125 levels. When we come to other options, Kelm is derived from CA125 during salvage chemotherapy. No, it is primary therapy, not salvage therapy. Third option is Kelm score requires only 125 measurements for calculation. No, it requires 3 calculations. Addition of option D, addition of third drug to carboplastin increases the Kelm's value. No, it doesn't take any additional drug therapy to the cancer. It is based on the primary chemotherapy drug. Question number 13. Which of the following molecule pathways is most commonly associated with high-grade serous ovarian carcinoma? See, high-grade serous ovarian carcinomas are defects in P53, P53 genes, and along with BRCA gene mutations. and they are homologous recombination deficiency disorders. So these pathways are key derivatives and carcinogenesis for high grade serous ovarian cancers, and rest all are other type of cancers. So the answer here would be 3, that is P53, BRCA mutations, and homologous recombination deficiency. The other options like KRAS and the HER2 mutations are not high grade serous ovarian cancers. They are a kind of low grade ovarian cancers. Question number 14. A 46-year-old woman presents with an XL mass. Transvaginal ultrasound shows unilocular cyst with smooth walls, thin septations, and no papillary projections. Doppler shows minimal vascularity. According to ORADS, ultrasound classification, this is most likely falls under the category. See, ORADS is radiological adnexal scoring data system. It has certain criteria wherein it looks into size of the cyst, nature of the cyst, content of the cyst, septations, vascularity, and any projections. If any of these changes are not there, that is 0. And if cyst is of less than 10 centimeter with simple non endometriotic or a kind of blood, the score is less than 1. The score is less than 10 if the cyst size is greater than 10 centimeters with septations with no vascularity, and upon adding vascularity it increases the score to 10 to 15. If vascular along with vascularity papillary projections are there, score is raised to greater than 50. So other options are not falling into this category. So according to this category, the correct answer would be B. Question number 15. 25-year-old woman is incidentally found to have 4 centimeter simple unilocular ovarian cyst. She is asymptomatic, regular menstrual cycles. What is most appropriate management? See, diagnosis of mere ovarian cyst doesn't indicate aggressive surgery. So it has certain criteria wherein based on the size, symptoms, and duration, we have to plan the mode of treatment. Coming to the cyst size, if it is greater than 5 centimeter and asymptomatic, the best management is to observe, wait and watch method. If cyst is symptomatic or greater than 5 centimeters or persistent more than 2 to 3 centimeters, then it should be an indication for cystectomy. So OC pills are the drugs which are useful for newer therapy, newer cyst identification, but not for a long-term statement. So the above said symptoms are corresponding for the wait and watch method. Other option, laparoscopic cystectomy, is not correct because that is of less size and asymptomatic. Option B, it is used for to prevent recurrence. CA 125 is not needed for typical young women. Question number 16. Which of the following statements about BEP regimen used in the treatment of ovarian germ cells tumor is correct? Remember, BEP is bleomycin, etoposide, and cisplatin. We should not confuse P with the paclitaxel. Here, BEP is cisplatin for ovarian germ cell tumors. Considering this, the correct option would be B, that is BEP consists of bleomycin, etoposide, cisplatin, typically given for 3 to 4 cycles, associated with pulmonary toxicity. Option A is wrong because P stands for cisplatin, and option C is wrong, plus this is inferior to BAC regimen. No, BEP regimen is the mode of treatment for germ cell tumors. Option D is wrong because BEP is only used in recurrent diseases. No, this is the primary treatment for ovarian germ cell tumors. This is the first line tumor, but toxicity is associated with bleomycin or pulmonary fibrosis, which has to be very much considered, and cisplatin induced nephrotoxicity and ototoxicity, and etoposide may cause myelosuppression. So considering this background, and BEP should be the first line therapy, and P is cisplatin, not paclitaxel. Question number 17. Which of the following statements regarding epithelial ovarian cancer is most accurate? The correct answer here is C. High grade serous carcinoma is strongly associated with TP53 mutations and BRCA mutation. See, Epithelial ovarian cancer are the most common ovarian malignancies, and they among them high grade serous cells are the most common and most lethal type. If and they are very much associated with the TP53 mutations and present in almost 95% of the cases. So and it is defects are associated with the homologous BRCA1 and 2 mutations. So, with this background, high grade carcinomas arise from endometriosis. No, endometriosis doesn't give hydroid this thing, high grade cancers. B is mucinous ovarian carcinomas is most histological subtype in epithelial ovarian cancers. No, that is serous ovarian carcinomas are more this thing. C is correct. Clear cell carcinoma are most common cancer subtypes worldwide. No, it is common maybe in the Asian subtype, but not worldwide. Worldwide, that is high grade squamous carcinomas are most common. Question number 18. Which of the following is appropriate management for low grade serous carcinoma, FIGO 1A after surgery staging? See, low grade and 1A, once surgery is done, we have to observe the patient. So the correct option here is adjuvant chemotherapy and other therapies are needed when the disease is very aggressive. Conditions like 1A and low grade 1A and stage 1A 1B, the treatment mode would be observation, and further based on the therapy and based on the severity, adjuvant and further chemotherapies are to be considered. Question number 19. Which of the following best defines pregnancy associated cancer? Pregnancy associated cancer definition itself indicates cancer which is diagnosed during the period of pregnancy or within 1 year of delivery. So, with this background, option A is wrong. That is not only in pregnancy. Option B is not within 6 months. That is 1 year. Option C is correct. Option D, cancer diagnosed at any time during. No. That is related to the pregnancy only. Question number 20. Which of the following structure is characteristically transected at the level of ureteric tunnel in type B? Hysterectomy according to the Kuller-Marrow classification. See, type B is modified radical hysterectomy is designed to protect the important structures like iliohypogastric vessels and to spare nerves along with the extensive dissection of the disease. So, what we do in this type B hysterectomy, that is modified radical hysterectomy, we identify the ureteric tunnel, we expose the ureteric tunnel and lateralize the ureter so that ureter vascularity is not damaged, and we remove the paracervix area at the level of tunnels in order to preserve the hypogastric vessels. And see, these are all are the characteristic features of the type B hysterectomy. So the correct option is paracervix B. The complete vesicovaginal ligament, no, that is spared. The type B hysterectomy is mainly to spare vesicovaginal ligament, that is called the bladder pillar, and inferior hypoglossal plexus and uterosacral ligaments are spared. So these three are very much spared with paracervix resection. Question number 21. 52-year-old women presents with postmenopausal bleeding. Biopsy. Cervical lesions reveals clear cell carcinoma of cervix. Immunohistochemistry shows negative P16, HPV DNA negative. Which of the following is most likely regarding her cancer behavior and expected response to therapy? See, as this patient is HPV independent and negative of this P16, and it indicates that it is HPV independent cancer. Usually, cervical cancers are HPV dependent cancers most commonly, and they are associated with P16. So, any cancer cells which are HPV independent are associated with genetic mutations and they are high grade and aggressive. Any cancers associated with HPV are low grade and most common. Based on this, the correct option is B. The tumor is likely driven by genetic mutation. Yes. The tumor is likely driven by HPV oncoprotein. No, because HPV testing is negative. B is correct. C, the tumor is likely HPV associated because HPV, no, that is wrong because HPV DNA is negative and other tests are also negative. The tumor is likely to have a better prognosis. No, that is also wrong because HPV associated cancer cells are have a good prognosis. Question number 22. 60-year-old women with gynecological malignancy is being considered for altered fractional radiation therapy scheduled to improve tumor controls and reduce late normal tissue toxicity. Which description best matches with the hyperfractionation scheme? See, this is a scheme wherein instead of giving radiation all at a time in a higher doses, the same amount of radiation is delivered in a small frequent, that is hyperfractionated, so that entire dose is delivered to the patient with a less side effects. That is the main aim of this thing. So the correct option here is reduced dose per fraction, increase the number of fractions, and relatively unchanged overall treatment time. So the correct option is correctly correlating with B. All other options are not relating to this. The main idea behind is, as I said, to decrease the toxicity and increase the sensitivity of the tumor and to deliver overall content. Question number 23. 30-year-old women diagnosed with post-molar gestational trophoblastic diseases. HCG is 75,000. Largest tumor size is 5 centimeter. And 6 metastasis, and there was an antecedent abortion, and there is no history of previous failed chemotherapy. According to FIGO staging, her total risk score is. See, there are FIGO staging gives risk scoring for this gestational trophoblastic diseases. So, considering her age and everything, as her age is less than 30, that is 0. Antecedent pregnancy, abortion corresponds to 1. Interval in pregnancy interval is less than 4, that is 0. And pre-treatment HCG is 75,000, that corresponds to 2. And the tumor size is between 5 centimeters, that's so above 5 centimeters, that comes to 2. And metastasis is to other areas are present, so it is 2. The overall score is 9. If you search, the FIGO clearly gives us the overall scoring system. Question number 25. Which genetic fusion most commonly characterizes low-grade endometrial stromal carcinoma and can be detected by FISH or RT-PCR? Most common abnormality is low-grade endometrial stromal cells sarcoma, which has recurrent translocation between T7 to 17 and P15 to 21. This translocation leads to the fusion between ZAS-F1 and SUS12, and this can be detected by using FISH and RT-PCR testing. So this is best answer is ZAS-F1 and SUS12. And this BCR and ABL are for chronic myeloid leukemia, not for this thing. PML and RARA are for, these are also for myelocytic leukemias. And EFW are for Ewing's sarcoma, not for uterine sarcomas. Question number 25, that is the last question. Which of the following statement about vaginal carcinoma location and types are correct? So when we go through all options, the correct answer would be HPV associated with squamous cell carcinoma typically arises in upper third of vagina, and HPV independent SCC involves lower third. Yes, these are all HPV, wherein HPV, that is human papilloma viruses, are colonized, is mostly in the cervix and the fornices. So the upper third of the vagina is the part where HPV induced changes are mostly seen. The lower part is not much associated with HPV sign. The correct option here is corresponding to A. Option B is clear cell carcinoma, occurs in usually, that is the upper 2/3, not in the lower third. Mesonephric adenocarcinoma commonly arises in the anterior wall of the. No, mesonephric carcinoma corresponds to lateral walls of vagina, not anterior wall. Mucinous carcinoma of intestinal types usually originate in the upper third of the vagina. No, that arises in the lower third of the vagina. So this is the entire question range for gynec oncology. all the classifications, especially the latest classification, for gynecologists, the FIGO classifications are very important. The latest classifications are developed in such a way that memorizing and mnemonics are based on the structures they are taking, so that it is easy to remember and make it more comfortable based on the therapy. And aggressive dissections are also have come down recent days. The advances and all the therapies are targeting mainly the sensitized areas and involved areas, not these are all to improve the patient outcome with less morbidity.